With that, I'm pleased to introduce our presenters for this evening and I'd like to thank you for joining us. First, we have Dr. Juan Ruiz, who is the lead allergist at the BC Centralized Complex Airway Clinic. And we also have Dr. Andrew Thamboo, who is the division head of otolaryngology at the Providence Healthcare Center in British Columbia. So thank you both for joining us and sharing your expertise and time with us and the community. And I'll turn it over to you, Dr. Ruiz, to kick us off.
Perfect. Thank you for the kind introduction. Let me share my screen. Perfect. Oh, share. Okay. All right. And can you see my slides okay? It's all right. Okay.
Yes, we
Perfect.
can. Yeah.
Awesome. All right. So yeah, I'm Dr. Juan Ruiz. I'm an allergist and immunologist. I work at St. Paul's with Dr. Thamboo, and we have created a special interest on this disease, AERD, which we'll be talking about today. And that's a link to my website and my Instagram that has some useful resources for patients with AERD. So first, I'd like to frame this conversation to raise awareness. A lot of people living with AERD, which is a disease that includes nasal polyps, asthma, and allergies to aspirin, are living out there without a clear diagnosis. And many medical professionals, unfortunately, are not familiar with the disease. So September 26th is ARD Awareness Day. Is an international movement to bring awareness to the disease, educate our peers, and empower patients to advocate for themselves to have better access to care and better access to diagnosis of such a cumbersome disease. These are my disclosures, which have no bearing on this talk. So in terms of objectives, I want to review what any AERD or NERD, what the advances are in the diagnostics. We're going to talk a bit about biologics and some of the updates in treatment. So what's in a name? Part of the confusion when it comes to NERD, AERD is that it comes by very different names. The first name for the disease was Samter's triad because it was described by Samter in the 1960s. And it was a triad, like I said, of asthma, chronic sinusitis with polyps, and allergy to NSAIDs. After that, the name was changed to AERD, which includes aspirin. So Aspirin Exacerbated Respiratory Disease. But this name was a bit misleading because the patients with NERD can react to many different NSAIDs, not just aspirin. So the most up-to-date name is NERD. So let's break down each of the components. So chronic sinusitis with nasal polyps is a disease of inflammation in the nose when patients can get polyps or growths inside their nose. It presents with loss of smell, pressure on the face, recurrent sinus infections. And the problem is that this sinusitis is very difficult to treat. A lot of times it ends up leading to recurrent surgeries, up to 4 to 5 surgeries in a lifetime. So that's why it's so important to have a good surgeon, a good team caring for you when you have an ERD. The second component is asthma. Now, asthma is characterized as inflammation of the airways. What patients feel is usually cough, wheeze, chest tightness, and difficulty breathing. Typically, it's eosinophilic, which means it's allergic in nature. And in this paper from 2005, it just shows how severe the asthma is. So less than 5% of patients with NERD will have mild asthma. And most of them have a decrease in their lung function. They have recurrent exacerbations, and it's more difficult to treat. And then in average, about 7% of patients with severe asthma have NERD. Now, the last part of the triad is the NSAID hypersensitivity. So another term that comes up is NSAID, which means a non-steroidal anti-inflammatory drug. So there's a big group of them. The most commonly known is aspirin, but there's ibuprofen, diclofenac, meloxicam, mefenic acid. So there's a big list of different NSAIDs, and they all block COX-1, or what's called cyclooxygenase 1. So part of the issue with the diagnosis is that there's many different NSAIDs, and sometimes the patient might not even realize that they're reacted to the anti-inflammatory after a couple of reactions. So my patients tell me it takes them 2 to 3 times to be exposed to, let's say, an Advil sinus that triggers an asthma attack for them to finally realize that it was the Advil or the ibuprofen. Now, to put it in very simple terms, this is the pathway which a lot of patients with NERD are affected. It's called the arachidonic acid pathway, represented by this letter AA. There's 2 enzymes, cyclooxygenase 1, which we talked about, and 5-LO. COX-1 right here creates a good prostaglandin, an anti-inflammatory prostaglandin that brings down inflammation typically. While on the bottom pathway here with 5-LO, you have the inflammatory leukotriene E4. So what happens is when you have NERD and you take an NSAID, we know that they block COX-1. You end up blocking the prostaglandin E2, which is anti-inflammatory. You lose that inhibition, and then you have overproduction of LTE4, which then results in sneezing, congestion, an asthma attack, which would be what you expect during an acute reaction to NSAIDs. Now, that's about 80% of reactions. 20% of the reactions are more atypical. Sometimes they result on gastrointestinal or abdominal pain. They could result in chest pain, and even some really rare cases in what's called a pseudo heart attack or a vasospasm of the arteries of the heart. Now, one of the things to consider with NERD is that the disease is in a state of flux, meaning it takes years to fully develop the disease. Typically, the first symptom tends to be nasal congestion, kind of nasal allergies. A lot of times patients will tell me that they'll have a viral infection, and after that, they start having congestion, and then they start developing other symptoms, typically followed by the sinusitis component, then the asthma, and typically the allergy to anti-inflammatories comes towards the end, years later. Now, this is not the course that every patient will follow, but most of them tend to do that. And that proves a bit difficult in terms of diagnosis, because you can have patients with polyps, patients with asthma, but then they haven't reacted to anti-inflammatories yet. So it proves a bit difficult to know if this is a patient just with polyps and asthma, or if they're actually on their way to develop NERD. So how do you diagnose it? It's a clinical diagnosis, and you need all 3 components. Asthma, you can diagnose with a breathing test. Chronic sinusitis with polyposis can be diagnosed with a camera up the nose or rhinoscopy, as well as imaging like a CAT scan. Now, for the NSAIDs, it's a bit more tricky, the NSAID allergy. You can have a historical diagnosis when there's a clear history when the patient would take the anti-inflammatory and they will react. But sometimes, like I said, patients haven't taken anti-inflammatories in years and they haven't reacted. So in those cases, we do what's called a challenge, a diagnostic challenge. So this is a paper that looked at very different challenges throughout the literature. And you can see that there's many different ways to do this aspirin challenge. Now, the challenge would be for diagnosis. So being a patient with polyps, asthma, and an unclear history to NSAIDs. So this is the protocol that we follow at St. Paul's Hospital. One of my mentors is Dr. Laidlaw, and that's the one that she has recommended and she developed. So you start at a low dose of aspirin, about half a baby aspirin, and every hour and a half, you increase the dose until you get to 325 milligrams. Typically, you're able to complete that in a whole day. Now, it's a very cumbersome procedure because you need to do a breathing test in between doses. So you'll be doing about 5 or 6 breathing tests, and patients will have small reactions like sneezing, coughing, wheezing. So they have to be monitored, and you have to resuscitate any during any reactions. You have to give them some antihistamines or inhalers. Now, as you can see, there's a lot of diversity in terms of the protocols. So again, there's a bit of lack of standardization on these protocols, and that's why it leads to a lot of diversity on the care that you would get depending on where you're located. Now, the difference between a challenge and an aspirin desensitization, the aspirin desensitization would be is done for treatment. So for example, the patient already has the diagnosis of NERD. They already have a history of previous reactions to NSAIDs. So when they're doing the aspirin desensitization, they'll follow the same protocol. The difference is they already have the diagnosis and they'll stay on that dose of aspirin forever. Because by staying on that dose of aspirin, it will prevent the polyps from coming back. So let's talk a bit about some advances in diagnostics. This is from a paper from Chow et al. That came this year, and they use intranasal aspirin lysine challenges, which is a nasal spray that has aspirin, and they use a visual analog scale that looked at symptoms as well as nasal manometry, which looked at the level of congestion. What they were able to find is that at a cumulative dose of 70 milligrams, they had a diagnostic accuracy of over 90%, which is really great. And they're able to titrate this up fairly quickly, taking about half a day, which is a lot faster than the way we're doing it now. The part that's really exciting is that less than 5% of patients had a significant asthma reaction. So again, this is pretty exciting news. Obviously, there needs to be replicated and there needs to be more studies. But I think one of the things that we're always looking for is how could we diagnose NERD patients faster and in a safer manner. Also, in a way that takes less resources, because again, typically an aspirin challenge or desensitization is usually a whole day procedure. So one of the big things or big news in AERD care is biologic care. I think a lot of times patients struggle to understand what a biologic is. In technical terms, it's a monoclonal antibody. Pretty much it's an antibody that is created in a lab that targets the inflammatory cascade. In this comic, I think this is a layman's way to describe what biologics do in the event that you don't have a whole lot of science knowledge. So imagine that under your immune system, there's a bad guy here sending wrong messages, telling the lungs and the sinuses to create inflammation, to recruit cells to inflame and destroy the tissue. And by sending those messages, you get subsequent inflammation, destruction of the tissue, you get severe asthma, you get polyps. What the biologics do is think of it as a CIA agent or some sort of military personnel that blocks those messages. So as this red man is, sending all these signals to say inflame, destroy, the biologics just block that signal. And by doing that, you're able to protect both the lungs and the sinuses. Now, this is a bit more complex, but it's the same slide. Pretty much you have the epithelial or the skin barrier in your sinuses and your lungs. You have inflammation that is caused by allergens, possibly viruses and bacteria. And once that happens, you start sending all these messages, which are characterized by the arrows, these bad messages of inflammation. Now, biologics, again, work by blocking those messages. So some of the available biologics for NERD includes omalizumab, which blocks IgE at this site, mepolizumab and benralizumab, which block eosinophils or the interleukin-5 pathway. Now, benralizumab works for asthma, but not for polyps. Dupilumab, which is an anti-IL-4 alpha receptor, which again blocks these, inflammatory messages. And more recently, tezepelumab, which hasn't been approved for nasal polyps yet in Canada. So those are kind of the biologics that we have available. Now, each of those biologics has a different schedule. As you can see, they're usually injections that go under the skin. You can inject yourself at home, and you can do it every 2 weeks, every 4 weeks, every 8 weeks. So each one of them has a different maintenance schedule. So one of the big questions that often comes up is how do you choose? I think the most important part is that you need to have a good relationship with your provider and explore the different options and find the biologic that works best for you. You should consider cost, coverage. And the part that we found really helpful with Dr. Thamboo is that when you do see patients together in a multidisciplinary approach, it's quite helpful because we can both have our input and choose the best biologic for the patient or the best treatment for the patient. And we could probably expand on that later on the question and answer period. But I think it's very important to have a good team behind you to helping you choose those biologics. So one of the questions that I often get is, do I have to be on a biologic to get forever? Could I reduce the dose? So that's a question that often comes up. So the initial studies that looked at polyps, for example, and asthma, if you stop the biologic cold turkey, yes, the symptoms tend to come back. However, there's been some studies now showing that you can play around with the interval and potentially expand that interval without having patients flare up. This is coming from Brigham Women's. This was a survey study, so it's an observational study. So you have to take it with a grain of salt. But what they did is they allowed patients to change their dose of dupilumab and titrated themselves based on their symptoms. And what they found that 25% stayed on the regular dose of dupilumab every 2 weeks, but they found that 38% were able to stay on that dose on the every 3-week dose, so expanding the interval, and 23% were able to stay on every 4 weeks. Part of the limitations on the study was a survey study, so it was self-declared. There wasn't clinical outcomes associated with it. But I think we're starting to see that perhaps there could be an effect on the dose, and we could perhaps be able to decrease the dose. Obviously, this is promising, but more studies are needed. But I think that's where the field is heading. So where does aspirin desensitization fit in, especially in this new world of biologics? Certainly at our St. Paul's Clinic, we have noticed a huge decrease in the amount of desensitizations that we're doing. I think there's still a role for aspirin desensitization, particularly when it comes to cost effectiveness. Dr. Thamboo published a paper looking at the cost for a single payer system, and it's quite effective in the sense of cost, but it does not work as well as a biologic. Here on the right, this is a meta-analysis, which is a pool of studies that get pulled together and reanalyzed to look at different outcomes. So what they did is they looked at all the biologics that were approved or that were studied for polyps, and they looked at different scores. And what you can see here for aspirin, you see this big red part here is from the studies that they found that the amount of adverse events was a lot higher than the biologics, particularly among gastritis or inflammation of the gut, and rarely bleeding, because unfortunately, when you take high dose aspirin, there's a risk of abdominal discomfort, gastritis, and rarely bleeding. So for that reason, we're using aspirin less, and also it does not work as well when you compare some of these outcomes with the biologics. So how does aspirin fit in this new world of biologics? We tend to choose it on younger patients under 40 years of age, especially after we do aggressive surgery. So you have a surgeon like Dr. Thamboo doing excellent surgery, cleaning out those polyps, and then we add the aspirin post-op. In terms of combination with biologics, there's more studies needed. There's some case reports and small studies that have looked at it may be helpful, but there's not enough literature to make a comment whether every patient should be desensitized. Now, interestingly, there's some preliminary data looking at some patients actually losing their aspirin allergy once they're on biologics, but again, that's still on its early stages. For now, to all my Scrub fans, I don't know if you guys watched Scrubs before, but I used to watch it. I think, you have JD here, medical, right? And then Turk being the surgeon. And I think that's a similar relationship I have with Dr. Thamboo. We've created this clinic to serve patients with severe, nasal polyps, NERD, asthma. And we kind of both learn from each other, and it's also a lot of fun to be able to serve these patients together. So I think one of the big messages from this talk is to encourage other providers to create this type of multidisciplinary clinics across the country to better serve patients and to learn from each other, because we've been working together for close to 3 years, and it's been a great experience. So I'll hand it over to my colleague Dr. Thamboo.
Awesome. Thank you, Juan.
No problem. Let me
All
see.
right. I love that photo. Uh, obviously, you get the guy with no hair. That's me. I'm gonna share my screen, share, and I'll put this in presenter mode. Thanks, Juan, for your presentation. It's even I learned a few things out of there. Yeah, I'm very fortunate to be here to be presenting to all of you on this condition. It's become, it's a hard condition to manage, and I as a physician managing it surgically, I can't imagine it being a condition that you want to have. It's a very tough disease to have, but I think if when managed well, you definitely have a better quality of life. And I think through this journey, we have really developed a kind of a center of excellence around this. And here I'm going to give you a few tidbits about how I see this condition and how we are doing it, at least from a surgical standpoint, improving outcomes in our patients with AERD. Similar to Juan, this is just my disclosures. Not sure where all of you are based out of here in Canada, but obviously Juan and I practice in a corner of Canada, and we service a really large province, right? Patients right across the entire province, and we have patients that are traveling really, really far away. We're not like the rest of the provinces where they have a number of major cities, which are more centralized to the province. I find that Vancouver is a very stuck in the corner, and as a result, say if you got a condition like AERD and you're an 8-hour drive, we really have to optimize you in each visit. And when I say in each visit, when they make that big trip all the way in, whether they're paying for the flight or they're pardon me, or they're driving, seeing Juan and myself and even the respirologist at the same time really optimizes their outcome, their experience, and more importantly to them as well, the pocket saved money in the back of their pockets. So these are some of my disclosures as well. And similar to Juan, a lot of them is around some of the biologic companies. Um, I'm very fortunate that when I first got hired here, I kind of had a split practice between clinical and research, and I continue to do research, and this is like a part of my team. And this is us in the operating room doing a bronchoscopy, so putting a tube down, a camera down their lungs and collecting tissue. So we collect tissue not only in the upper airways, which I'm in there all the time, but in the lungs as well, and allows us to do some really fun research on patients. Kind of what Juan has alluded to, we do multidisciplinary care, and one of the visions of of seeing people with upper airway disease and lower airway disease is that we obviously want to dramatically improve your quality of life with those suffering with airway disease, so upper and lower airway disease. But we also wear the cap because we work for the government. We want to make it cost effective. And, when we talk about drugs like biologics, they can be expensive. We want to make sure we're using them in the right manner. In some provinces, they're covered by the province. And in some provinces like British Columbia, they're not covered yet. So, it's a struggle to make sure that we're being cost effective and giving the best outcomes for our patients sometimes in a socialized healthcare system. I kind of want to give you this journey, and again, I want to let you guys realize that I appreciate that the journey of a patient is tough. You know, typically, You may go see your family doctor. You complain of some nasal symptoms like congestion. They give you nasal steroids. They say, come back. Well, you come back, and now you say, well, now I lost my sense of smell. What they usually say, continue to use your nasal steroids. And then things start to get worse. And people that have like an aspirin sensitivity or an ibuprofen sensitivity, obviously have asthma as well. And like in this typical patient, they may get an exacerbation, end up in the emergency department. Only obviously when things start to escalate to a certain degree do you start to get referred to a specialist. And say like this scenario, you get referred to an ENT, but like in our healthcare system, just seeing an ENT can take months in itself. So you get referred and you start on some what we call appropriate medical therapy for possible chronic sinus disease, but we have to do investigations. And when we do investigations, again, we're relying on a system where we have to wait for investigations to happen. So in my world, I get a CT scan. A CT scan is very important because I kind of want to look at how extensive is your disease in your sinuses. Um, I may see that patient and refer to a respirologist because I feel it's important. Luckily for us in Vancouver, we've created a system for centralized care, so it's been a lot faster. But other institutions across Canada, you may not have that ease of access. So you're waiting for now a lung doctor to access you. And then you're fast forwarding, you're many years later since the time you presented to your family doctor, and now we're saying, okay, you actually need sinus surgery to get better. And that journey can be really quite tough and long for patients, and I appreciate that. I don't know if there's a better solution right away. I think we're working on solutions, small things at a time here in BC and Vancouver in particular. Um, but I just want to say that we understand and appreciate that that journey is long. Now, when that journey is long, and you're not improving, there's things that are happening at the tissue level. And what Juan was kind of explaining with these amazing diagrams that are also confusing to me as a surgeon, that you have this inflammatory process that's impacting the tissue. And at the end of the day, we're dealing with a tissue disease. And similar to, say, when you get a callus on your hand from like hard work and you do a repetitive work with your hands, the tissue on your hand starts to remodel, meaning it starts to change and you get these calluses. In your sinuses and in your lungs, you tend to get that type of remodeling that happens. So when you've got chronic inflammation, that's going on in your upper airways and lower airways, you start to get some changes in that tissue. The problem with that, the changes in your tissue can be a bad thing. One thing that we appreciate for upper airway disease is that when that tissue starts to change over time, so if you're waiting for 2 or 3 years to finally get some management, that tissue is changing, and unfortunately, those symptoms that you develop are harder to manage. More importantly, what we found is that when you also don't manage the upper airways well, you get more correlations to developing asthma. And, they find this in the UK. Canada's not the only healthcare system that struggles with wait times. In Europe and UK specifically, they struggle with that as well. And as you can appreciate, even from um, the study, they took 2,000 patients, almost 3,000 patients actually. And the longer they waited for upper airway management, in particular sinus surgery, they had more correlations to asthma disease. And we see this basically, it's if you get inflammation here in our patients, that inflammation can travel down to your lungs and exacerbate the lungs. Um, Now, why does that matter, and why do I always tell patients that you should really care about your upper airways? You should care about your upper airways, because if you if the upper airways can make the lower airways bad, it's important to care about those upper airways. And that's why, people like Dr. Ruiz or respirologists have started to combine their care with us because we can optimize the lungs by doing a better job up here. Because at the end of the day, just like Dr. Beach was showing to you, asthma can kill. So if you have severe asthma, you're 4.8 times more likely to die than me, who doesn't have asthma at all. Or if you have mild to moderate asthma, you're 2.9 times more likely to die than me. And that's a real thing to think about. So I think, I take that seriously, and I think that's why, people like Dr. Ruiz and I kind of work together to sure that we optimize the upper and lower airways. In terms of understanding why we see so many patients together, is that a lot of patients who have upper airway disease also have asthma, COPD, bronchiectasis. These are all the different conditions that one can have in the lungs. Now, what the heck am I doing inside the nose? Well, you know, the goals of sinus surgery, and I explain it in multiple different ways, is to decrease the inflammatory load. So the inflammation in the nose, we try to decrease it by taking it out. More importantly, we're trying to put something in, which is medications. And the way I explain it is think of it like a 1990s house where you have like a living room, a family room, a dining room, they're all separated. There's, you have to enter one room, then exit that room and enter another room, exit. And now you fast forward to 2025, and basically you enter the front door, and guess what? You can see the back door, and all you see is, the living room, the kitchen, the dining room, all kind of in one big, great room. And why that's great in sinus is because when you wash down the front door, it kind of can bathe the entire walls and go out the back door. Versus if you're in like in a 1990s house, it's really hard to put medications through the front door and make sure it hits all the walls. So, I mean, that's kind of the simple way of how we look at it. This is how the nose should look after surgery. And I'll kind of slow it down here and point out a few things. Obviously, I don't not expect you guys to know the anatomy here, but if you can see my arrow here, that's the cheek sinus, and like this sinus just behind under your eyes, and this is the sinus that's actually between your eyes and called the ethmoid sinus, and etc. But more importantly, what I want you to care about is how the tissue quality looks like. And this is normal tissue quality to us. There's no polyps anymore, there's nothing. But more importantly, it's really wide and open so that you can put medications in. What makes this kind of scary and dangerous is because, and I'll try to get in the right image here. This wall right here, think of it like I've just entered the front of the door, and the only wall I want to see in 2025 household that's being built is an outside wall. And for us, this wall right here is the wall that separates the nose and the eyeball. Okay, so the only thing separate, and this here is the only thing that separates me is the nose and the brain, right? So there's no other wall in between. So when I put medications into our nose, it's going to bathe the walls that I can't touch. So at the end of the day, when you do sinus surgery, you want to have it nice and open like this so that when medications go in, it can do its job for the walls that you can't take down. Okay. So that's kind of a 101 on sinus surgery, but it's funny. I have some patients that always ask me, give me all the details. And I say, oh, you got to come do med school and residency with me, and I'm happy to show you. But hopefully that gives you guys an idea of what we do. So with that, I think we'll open up to questions. And obviously my Instagram there is also UBC_rhinology. And I know Dr. Ruiz and I are happy to take questions.
Great. Thank you very much to you both. That was fascinating, very interesting. And we have some questions that we're going to cover. Just before we do, though, I want to take a moment to highlight Asthma Canada's Asthma and Allergy Helpline. You can see here on the screen the number, toll-free number to call. We can also entertain questions via email. This is a free service that we offer as a charitable organization that operates across Canada. It's available in English and in French. And when you call or email in, you will hear back from a certified respiratory educator who can entertain and address any questions that you may have, whether you're a patient, a parent of a child diagnosed with asthma, if you have questions about asthma, about allergies, conditions like AERD or NERD, any of those questions, we can help you. So we encourage you to please reach out at any point in time. So with that, we are going to open the floor to questions, and I would encourage people, if you have questions that you'd like to ask either or Dr. Ruiz or Dr. Thamboo, please put them into the Q&A and we'll do our best to cover them. But I'll kick things off with just a couple of questions based on some of the questions we received in advance. I know one of the things that you covered, Dr. Ruiz, in your presentation was an explanation of biologics and what they are and how they work. So for patients who don't qualify or may not have coverage, you mentioned obviously that there's differences and disparate coverage in different provinces, but what does optimal management look like, and how do you set realistic expectations if biologics aren't currently available for that particular patient?
Yeah, no, great question. I'll split it into two. First, you want to optimize medical management, just as Andrew was mentioning, the nasal rinses using a steroid to reduce inflammation. That's the first step. So get optimizing that, increasing the dose. That could help in many cases. If biologics are not available or the cost is too much, again, having good surgery. So, not all surgeries are the same, not all surgeons are the same. So having a surgeon that specializes in this type of disease, in these types of surgery, that would be quite helpful to, again, reduce the burden of inflammation, make big holes, as Andrew was saying, to get the medication in there. And aspirin desensitization, if it's available where you live, it's quite affordable. I think it's about $65 a year if you use the aspirin over the counter. It's very cheap. We know it does work. And if that's available, that's something that can be explored with your team.
Great, thank you. Dr. Thamboo, you talked about the importance of having the right surgeon, the right team. I think, the two of you kind of operate as a dream team, I guess we could say, in terms of your practice and the work that you do together. But knowing that it is really important to have the right surgeon from a system perspective, what do you think needs to change so that more patients can consistently get that type of specialized care that you offer?
Yeah, I think it's an evolving process. I do think the educational program that we have across Canada is pretty good, and the people that are coming out of training are getting better and better at getting the right training for doing sinus surgery. I think there's a lot of sinus courses and those aspects that are helping, middle career surgeons do this. The reality is, this is a specialty that's only starting to evolve with technology, right? And technology is like something that is being brought in into the academic centers. And if you didn't get trained during that time, you just haven't had an opportunity to learn that. One thing we are doing is doing these courses across Canada to allow surgeons to to get up to date with the skills required to be more complete when they do their sinus surgery. If I was from the patient standpoint, I think most major academic centers have people that are well trained. They are up to date on the way they manage this condition. I think ARD is a tough condition, so I think it should be managed by people who are tertiary. And when we say tertiary, they're mostly in academic centers.
Thank you. Just carrying on with you, Dr. Thamboo, we had a lot of questions that came in about the recurrence of nasal polyps post-surgery. So how do you set expectations with patients before surgery or as they're going through the process? And what can you say to people who are concerned about the recurrence of nasal polyps?
Yeah, I mean, it's tough. I get it. Like when you go for surgery and you put yourself to sleep, you kind of want it to be one and done. Like I totally understand that. I think it's setting expectations is the first thing. Let you as a surgeon, but also as a patient, and understanding what's your disease. Like if you know you have really mild inflammation, guess what? The chances of you doing sinus surgery and never having recurrence is likely going to be great. Like you're going to have a great outcome because you're going to get the topical therapies in there and it's going to be enough to get a good outcome. Now, if your inflammation is really bad, and that's unfortunately in the setting of AERD, like if your inflammation is really bad, your chance of recurrence is much higher. Now, people are like, then why do I bother with sinus surgery if I'm just going to get recurrent polyposis again? The reason why is because you want to decrease the amount of inflammatory load that you have up here and combine it with other medical therapies that can counteract the remaining inflammation you have in your system. So, for example, I always tell patients this explanation that if you have this much inflammation in your body and we bring it down to this much, but you still have this much left, if I don't give you enough anti-inflammatories above this load, you're going to get recurrence, right? And if you have AERD, sure, you're going to have some degree of inflammation still in your system because you're constantly making inflammatory markers. And it's our job to figure out, what that looks like. Is it aspirin desensitization? Is it just pulmicort saline irrigation, or is it biologics that requires you to get the outcome you need to be greater of anti-inflammatories to the inflammation in your body? And that's how we prevent recurrence.
Thank you.
And one thing, if I may add,
Sure,
before we go,
please.
is when we see these patients together, we always tell them we're going to be more aggressive in your care because we know the tendency is for you to fail. So our goal, like what we hope to do, is to have the one surgery and not need any more. Obviously, we might not always meet that goal, but that's our goal. So part of it is aggressive surgery, aggressive rinses, and also constant follow-up. A lot of times what happens is post-surgery, things might be good for a year, then the patient gets discharged and 2 years later they come back, right? So also having a close eye and seeing those polyps, if they start coming back, then we can act on time before things are too late, or yeah.
Yeah, it's obviously a very complex condition and complex treatment plans. So we're very fortunate that we have folks like yourselves who are specializing in this area, which we hope to see more of. And going back to the previous question around biologics as well, that's one of the things that we're doing at Asthma Canada. And I know we work with healthcare practitioners such as yourselves who are helping us to advocate for better treatment options so that people, regardless of where they live, will have access to biologics or will have other forms of treatment as they become available. So that's something we continue to do, and we appreciate your support as we do that on behalf of the patient community. When it comes to NERD or AERD, are all NSAIDs the same in terms of sensitivity? So, for example, if someone is sensitive to ibuprofen, does that mean it also affects them in terms of aspirin, or are they different? And I'll just throw that out to either of you too.
Yeah, I would say, yeah, they are. It's all based on the mechanism of action. So most NSAIDs block COX-1, or they're called COX-1 inhibitors. So in NERD, they're all just as reactive in my book. So ibuprofen, diclofenac, Midol, any anti-inflammatory, if you react to one, you'll likely react to others. That's the easiest way to communicate. There's one anti-inflammatory that works through a different pathway called Celebrex, and it's a COX-2 inhibitor. So it goes through the cyclooxygenase 2, and that one is typically well tolerated. So that's what I would use for pain in patients with NERD. They can use Celebrex, or they can also use Tylenol. Now, interestingly, with Tylenol, at high doses, Tylenol can be a COX-1 inhibitor. So some patients with very severe AERD, they can have symptoms of when they take more than 1 gram of Tylenol. So typically, again, there's something to discuss with your allergist, but I would say any COX-1 inhibitor you should probably avoid.
Okay, great, thank you. And that covers a few of the other questions that came in about what can I take for pain.
Yeah,
So thank you for addressing that in your answer. I appreciate that. So we've had a question that's just come in live. Let me see. I'm just going to read it through here. Do you discuss food cross-sensitivity with aspirin with patients? Is this important for asthma flares? A diet for someone with an aspirin sensitivity should focus on avoiding high salicylate foods, which include many fruits like berries, avocado, vegetables, etc., beverages, coffee, wine, etc. So can you comment on that aspect in terms of managing this disease?
Yeah, most definitely. I usually recommend my patients follow the low omega-6, high omega-3 diet from Brigham Women's. You can find it on the samterstriad.org website. But pretty much you reduce things that have high omega-6, like steak, egg yolks, avocado, because those tend to be pro-inflammatory and can give you a flare-up of your symptoms, and try to increase things like flaxseed, fish oil that are more omega-3 and more anti-inflammatory. So there's a small study that actually showed that there was a decrease on inflammatory markers with the diet and a decrease of symptoms. But it was a small study and it was short. But for me, I've certainly anecdotally noticed a significant improvement. The salicylate diet was kind of dead for a bit, but there's a new study that showed that it may work. The salicylate diet and the low omega-6 diet are similar. I would think it's a lot easier to follow the low omega-6 diet. So that's what I usually recommend to patients.
Great, thank you. We had a question that just came in as well in terms of the websites that you recommended for information. So our website, Asthma Canada, asthma.ca, Samter's Triad, and maybe we can put that in the chat as well. Is it samterstriad.org?
Org, I think.
Yes.
Let me double check. I think so, yeah.
And then we'll drop that in the chat so people can take note of that as well. So while we're doing that, perhaps a question for Dr. Thamboo. What are some of the innovations or surgical techniques that might be on the horizon that give you the most hope for better long-term outcomes in AERD?
Yeah, I think like, one of the key things is not when we say aggressive surgery, it's really getting to that boundary. And that when we talk about that boundary, it's the orbit, the eyeball, and the skull base, which is the brain. And, like creating safe ways for surgeons to do that. You don't have to be a high volume surgeon to always achieve that. So I think nat like what we use this we use something in the OR called navigation. It navigates us like a GPS system to be safe, to get as close as we can to these areas of concern. So, making that one just available to all surgeons across Canada that do sinus surgery. We don't, in BC, we're really good about having most sites that have it, not saying all sites, but most sites. But across the country, it's pretty bad actually because they're expensive products. So making them affordable, more accurate, so that surgeons can use it to say, okay, that's the eyeball, that's the skull base. I feel comfortable and safe, and having that kind of available for all people.
Thank you. We often talk in terms of asthma management in general about understanding triggers and sensitivities. For some people, scents or household items, perfumes, air fresheners, things like that. Do you find that perfumes and other household products like cleaning chemicals and so forth are particularly impacting people with AERD, or is that something that just you would consider just in terms of understanding triggers from an overall management of asthma perspective?
Yeah, I certainly think that NERD patients tend to be a lot more reactive. They tend to have a lot more, I would say, idiosyncratic or strange reactions compared to regular people. So certainly scents can trigger asthma in this population. So typically, just as in regular asthma, I tell them to avoid triggers, wear masks if they're in a place where there's a lot of scent. But certainly, yes, their immune system is overactive. So it's not unusual for them to, when you're taking that allergic history, they have several allergic reactions to other things that are not NSAIDs.
Right. Yeah, that makes sense. Are there other let me put it this way. Is it always a triad or because some people have asked questions around, they notice that their ibuprofen, for example, makes their asthma worse, but they don't have any symptoms around CRS with nasal polyps. So is it always a triad, or can it be something that is one or the other type?
Yeah. So that's a good question. So I guess the first point is, if you remember that slide that I have, the condition evolves over years. So it doesn't all happen at once. So you could be at the stage when you're just having the polyps, right? About to develop asthma. And at times the aspirin is the last one that comes, right? So it could be that maybe even with enough time, the disease becomes clear, right? That's one option. The other thing too is, yes, there's always this saying in medicine that some patients don't read the textbooks. Patients could present with atypical presentations. So there is a category called blended NSAID reactions, where again, it doesn't fit the nice box of NERD, and you can have like severe NSAID respiratory reactions, but no polyps, right? And no asthma. So at that point, it wouldn't technically be classified NERD. It would be more classified as a blended reaction. And we don't understand them as well. I have a couple of patients with those types of reactions. And again, they don't follow the same pattern, right? A lot of times they don't even have bad asthma or polyps, but they have these severe, respiratory responses to NSAIDs. So again, I think more research is needed on that one. But I would classify those as evolving NERD or blended reaction, a completely different entity. Yeah.
Thank you very much. So I'm going to ask one final question to both of you, and perhaps you can both respond to the same question. If you've provided a lot of great information, and we thank you for that. If you could give one piece of advice directly to patients who are listening today or watching the recording of this webinar at some point down the road, who suspect they may have an ERD, what would it be? What would that one piece of advice be?
Wow, yeah, like suspecting NERD. Okay, so like you're not sure if you have it.
Correct. Not diagnosed.
Yeah, I think the key part is appreciating that there are stages to this condition. I think a lot of physicians and patients don't realize they're on that journey towards that diagnosis. And just because you get seen at one stage, say you just have polyps and you don't have your aspirin sensitivity yet, that, like if you're a person that's revisiting and seeing your ENT, for example, with recurrent nasal polyps, do you have AERD or NERD? If that's a patient that you're presenting with recurrent nasal polyps, try an aspirin, try an ibuprofen, because then if you're on that spectrum. More importantly, I don't think many physicians ask about it too, like ENTs. Look, it's a misdiagnosis because people aren't asking about it, and therefore they're not recognizing that these patients are the difficult patients, and they're not getting the complete care that they require.
Yeah, yeah, excellent point. And I think that's why we're doing this webinar. That's why we're promoting the Awareness Day on September 26th for this year. So thank you for that. And any closing thoughts that you might want to add on to that, Dr. Ruiz?
Yeah. I think, one of the things too that's important is the baseline therapies. Like a lot of times we get really excited about biologics, aspirin desensitization, but sometimes it's about the simple things. If you rinse your nose, most times it'll be great. A lot of part of the issue is patients stop wanting to use their medications or they don't get as compliant. And I think if you understand that it is a chronic condition, right, it's not going away, but if you can keep that level of inflammation down, you'll do better. The problem where I see there's a lot of worsening of the disease is when the patients start withdrawing therapies, and then they don't rinse their nose, they don't do any of the treatments, and that's when things get worse. So understanding that it is a chronic condition, and that by using these steroidal rinses, right, these inhalers, that you'll have things under control, and that you don't have to be afraid of steroids. There's a lot of steroid phobia nowadays, and that these are perfectly safe medications, and that they work well.
Excellent. Those wonderful answers, both of you, to that final question. Thank you so much for joining us and presenting this information in a way that I think a lot of people will appreciate and understand. So thank you both for your time. We appreciate that. We thank those of you that have joined us live, as well as those watching the recording at a later date. We ask you to please take a moment, if you could, fill out our post-webinar survey. There's a QR code on your screen that will take you directly to the survey. That helps us plan future educational activities like this one. So we really appreciate it if you take a moment. Also, just quickly wanted to mention that if you found today's session valuable and you are so inclined to do so, Asthma Canada is a registered charity, so we do rely on donor support to offer the programs and services and educational endeavors like this one. So if you are able to, we ask you to please consider making a donation. Again, there's a QR code on your screen, or you can visit us anytime at asthma.ca donate. We appreciate all and every donation that we receive. So on behalf of our team at Asthma Canada, I want to thank you both, Dr. Thamboo and Dr. Ruiz, for joining us for this great session. I want to thank everyone who's joined us live and those that are watching this recording, and we wish all of you well.